I think there should be no one anywhere in any part of the world who should be walking around with a defect on the face, and you can treat any patient in any corner of the world. And I think in India, we have been able to do it frugally.
3D printing technology is pushing the limits of customization, bringing ease to surgical planning and making predictable outcomes. If you are a surgeon wanting to make lives better, you are in the right place. Welcome to the Surgeons in 3D Printing podcast. And now, your host, Dr. Ruchi Pathak Kaul, to take you on this beautiful journey.
Welcome to the Surgeons in 3D Printing podcast, and today my special guest is Dr. B.Srinivasan, the Chief Executive of Enhance Head and Neck Rehabilitation. He is the consultant at Ruby Hall Cancer Center, Pune, an alumnus of Government Dental College, Mumbai, and he started his illustrious career in Maxillofacial Prosthodontics at Tata Memorial Hospital, Mumbai. So for all the prosthodontists here, there is a great opportunity to connect and learn from his experience. He has a course which he is hosting, which has both online and offline modules, which we will be talking about in this podcast. So here we are. Let's welcome Dr. B.Srinivasan. So welcome to the Surgeons in 3D Printing podcast, and I'm here to welcome Dr. B.Srinivasan. Hello, sir.
Hello, Ruchi. How are you doing?
I'm good.
Thanks for having me over.
Oh, yes, of course. And I would say that I think it's been like a year and a half or maybe even 2 years ever since we've been talking about you coming over to the podcast.
Absolutely. It's been a while, and something or the other has always been coming up. And I'm glad that it's happening today.
Yes, I wanted to really ask you first about your journey, because we have listeners from different aspects of dentistry and medicine. So we wanted to first know that how was your journey with maxillofacial prosthodontics?
Okay. So this has been quite a long story. And in the sense, I was always wanting to do orthodontics after my BDS. After I completed my graduation, and to an extent, I had done a small project as well during my internship. So ortho was my passion during my initial years. But then somewhere beyond internship, when I actually started studying for the entrance exams, that's when I realized the scope of prosthetic dentistry. And that's when, as I started reading a bit more, I felt generating or developing a bit of an interest in prosthetic dentistry, and more specifically maxillofacial prosthetics. And that's when I reached out to some of the cancer surgeons that I knew and asked them if there was indeed any kind of scope for this kind of branch in the future. And most of them seemed to be encouraging me to take it up. So thankfully, I had this option after my entrance exam to pick up prosthetic dentistry, because I did not have the option of orthodontics in front of me. And that this happened to be my second choice. But in hindsight, I'm glad that I took it up. 3 years into my master's program, and as I started venturing out to the other hospitals in Mumbai, I completed my post-graduation from Government Dental College and Hospital, Mumbai. And during my entire postgraduate curriculum, I used to make it a point to move around into some of the hospitals and speak to the surgeons there as well. And 3 years later, when it was time for me to complete my program, I felt the urge or the need to hone my skills a bit more. And that's when I started looking around. To be honest with you, a lot of my teachers discouraged me from taking it up because they felt that there was no real scope. But I had sort of made up my mind and to sort of do something more. I was looking for the right kind of opportunity where when there happened to be a senior registrar's post at the Tata Memorial Hospital.
Okay, you started your journey with the Tata Memorial, and yeah, a little bit about that, yes.
Yeah, so that was a completely, life-changing journey for me. I happened to be at the Mecca, if I may call it, the Mecca of oncology in Asia, and I was surrounded by highly professional people, motivated, enthusiastic, supportive, and I think that really cemented the idea of continuing with Max5 prosthetics for the rest of my life. So my initial tryst at Tata Memorial Hospital was actually laid the foundation for many more things to come. So I spent a couple of months at the Tata Memorial Hospital. We used to see almost about 80 or 100 patients a day. Um it was gratifying to say the least, and also highly supportive staff there in the department, very supportive surgeons, and it was I was really enjoying my time there, and this was way back in 2004. But a few months down the line, I felt that yes, the volume was there, but I felt the need to hone my skills a bit further, and that's where I started. Those were the days where the internet was beginning to open the doors for a lot of us, and it gave me the opportunity to start looking around for opportunities, to overseas. If I could go overseas for training and then hone my skills there, I chanced upon the Union for International Cancer Control, the UICC. They were giving a grant for young investigators and clinicians who wanted to hone their skills overseas. And I also happened to chance upon the website of the International Society for Maxillofacial Rehabilitation. And this society was initiated by Dr. John Bumer, whose textbook we had read, and
Yeah.
I was completely in awe, of the entire activities of the ISMR then, and I started emailing everyone. I became a member immediately, and I started emailing everyone there on the membership roster. Some people responded, many didn't, and uh, but the opportunities were not opening up. So it took me almost a year or so of continuous emailing, just copy pasting those emails to people. And I happened to reach out to Dr. Rob Fanot, who
Oh,
was
wonderful.
who had completed a tenure as the president of the ISMR. He had done some outreach programs in Mongolia, and but he wouldn't respond. But I kept pursuing him. I felt, I mean, I was in awe of what he was already doing. He was a pioneer in the Netherlands, and I had read a lot about him on the internet. And I thought I felt the need to sort of reach out to him for some kind of training. It was very difficult to go to the US because you had to complete your DDS,
Yeah.
and had to be going in for a full blown program, and that was a long journey. And because I did not have a DDS degree, it was making things very difficult, for me to apply. But here was an opportunity where, after almost 2 years, Dr. Rob Fanot just sent a one-liner: "Send me your CV."
Oh, wow.
I think, and beyond, and after that one-liner email from him, I think there has been no looking back. So then we started some initial discussions. I think he was probably testing my patience and relentlessness to sort of keep pursuing at it. This is what he told me a couple of years later.
Okay.
That's what clinched the deal for me. So he gave me this wonderful opportunity to visit the University Medical Center in Groningen in the Netherlands, and this was in 2005. Towards the end of 2005. And I was fortunate enough to get two cancer fellowships, one from the Union for International Cancer Control, the UICC, and also the Delta, or the Dutch Education for Learning, which came from the Rijksuniversiteit Groningen again, the university there. So
Yeah.
this sort of opened the doors for me. And when I was there, uh, uh, it was wonderful. Whatever I had read in the textbook
You
was
could
all
see.
being practiced there. So it was like a dream come true. and the people, Dr. Rob Fanot, now I call him Rob because at the end of my training program, he said, "Don't call me sir, call me Rob." So I mean, I was not even. That was my first, you know. Travel. That was my first tryst with anyone overseas. I'd never traveled overseas before, so I was completely oblivious to the fact that people are called by their first names there,
Yeah,
not
exactly.
as sir or Doctor Fanot, as as we call in India,
Yeah.
yeah, out here. So the kind of exposure that I got from Rob, now I call him Rob, and his colleague, Dr. Harry Reinsima, Harry to me now, uh, were out of the world. The kind of knowledge that I got from them and from all the other colleagues, in the department at the UMCG, there has been there to stay with me for the past well over 20 years. It's now 20 years since I went, so it has stayed with me. And the best part is what I share with the kind of relationship that I share with the people in the UMCG today is more personal than professional. And I think I value that much, much more today. And in
Definitely.
those initial days of the internet, when I came back to India, I felt depressed because you see all the things that are done by the book there, and you come back here only to see that things are still not organized
Yeah.
here. I wanted to just add a few things of what I observed in the Netherlands
Okay.
vis-a-vis, what was happening really in India. So the thing is, these kinds of meetings, the tumor board meetings, where the prosthodontist is also involved, was something that was new to me,
You
because the tumor board does happen in India as well, and it's been happening in India for a very long time. But a prosthodontist has never been traditionally a part of the tumor board. And these reconstruction meetings, where all these things between the decision making between the prosthodontist, the plastic reconstructive surgeon, and the oncosurgeon happening at the same time is something that I saw there for the first time. And believe me, even after 20 years, there are still there's lots to be desired. I mean, it's improved by leaps and bounds over the last 20 years, but I think we still have a long way to go. The surgeon there said, "We do not pick up the knife till the reconstruction team gives us the permission to do so." I mean, it speaks volumes about the kind of importance that the oncosurgeons give to their reconstruction and rehabilitation teams there.
I wanted to know about your center, which is called Enhance. And I wanted to
Mm.
know, like, what were you looking at? Why did you open that? Obviously, as a general practitioner, we all do go for the same. But I see a larger vision involved in your case. So I would really want to know what's your vision behind it? What are the needs which you feel they are not met yet? And so, yeah, a little bit more about that.
Yeah. So the thing is, one of the few things that I realized was that across the world, the prosthodontics or max spec prosthodontics has always been a subset of a hospital in a hospital setting, and it's not often that you see a rehabilitation center for head and neck defects in isolation. But the situation in India is different from that overseas. Say, for example, in the UK, it's driven by the NHS. In Europe, in many countries, it's state funded. In America, it's largely driven by insurance or covered by insurance, I would say. But in India, 85% of the healthcare system lies in the private sector, and it's largely driven by private hospitals, now corporate hospitals, and there are specific departments, all of them working predominantly independent of each other. And even if you have a dental department as part of a larger hospital, it's still called a dental department. It doesn't. There is no department for maxillofacial prosthetics in most hospitals even today, which means the entire specialty was facing an identity crisis. People outside did not even know, right from the hospital management to the public, were not even aware that there's something called head and neck rehabilitation. And that's where I felt that the first thing that needs to be done is to give this entire specialty an identity, a separate identity, so that you can start introducing yourself as a maxillofacial prosthodontist and not just a prosthodontist. So it's been almost 15 odd years since I started putting on my resume that I'm a maxillofacial prosthodontist, and the difference between a prosthodontist and a maxfac prosthodontist in the kind of scope of work that we really do. And ever since I started doing that, I felt that there were curious questions. What is head and neck rehabilitation? What does a maxfac prosthodontist do? And those the answers to those curious minds, I felt laid the foundation for giving maxillofacial rehabilitation a boost. And that's the reason why I started a separate started giving a separate identity for in the name of enhance meaning enhancing quality of life, and head and neck rehabilitation, as it is self-explanatory. Till 2014, I was treating patients for sure, but I was doing it under as part of a dental private practice.
Yeah.
And to give it a larger picture, I felt the need to give it a separate identity, and hence I gave it a separate name altogether.
Right. But then what is your model of work, like the hub and spoke model that I've heard of? I'd like to
Okay.
know more about it. Yes.
All right. So what was really game changing was my visit to the Aravind Eye Hospital in Madurai, in the southern part of India, in 2012. And one of my patients, by name Sriram, actually was he met me once in the clinic, and he saw a patient with a Riles tube, sitting in the OPD, and he asked me who that patient was, and that set the conversation going. And he was actually a management guy. He had a background in management, and he motivated me to paint my ideas on a larger canvas. And with him, I went to the Aravind Eye Care Hospital, in Madurai, which treats about 100,000 cataract surgeries absolutely free of cost.
Yeah.
And another 100,000 cataract surgeries which are paid. And this was a Harvard case study for philanthropy. The kind of work that these people are doing, how humble they were, and how they had scaled up impact was something that I was in awe of, and that changed my entire perspective. And since then, I wanted to sort of replicate, or at least take some cues from their model into head and neck cancer rehabilitation. So after that, I was still thinking as a clinician, of treating patients. I did not have the experience of how to really even think about scaling up. So that's where I decided to go ahead with a short fellowship in social entrepreneurship through an organization called Unlimited India. And during the COVID lockdown, I did the Stanford's Seed Spark program online, which gave me further insight into the basics of entrepreneurship. And that's where these things started showing the seeds of trying to scale up Enhance from a small clinic situated in Pune to sort of something which is bigger, pan India, where I can involve more and more people and sort of treat patients. Because I possibly cannot treat every patient, but I should be able to facilitate treatment of a lot of patients by working on a hub and spoke model. So as a clinician, way back in about 10 years back, I did not even know what hub and spoke means. That's why after going through these kinds of programs and talking to a lot of people, I realized that if you have to create an impact, you got to scale up. And the eventual idea was to use digital technology, to boost the clinical services, where you have a central hub in the city of Pune out here, but you have multiple spokes across the country to start with, and if the model works, probably replicate in other parts of the world as well. So that's definitely a vision where you can't treat every patient on the face of this earth, but you definitely can facilitate it by effectively harnessing digital technology. So in 2016, I teamed up with a group with an engineer and a polymer chemist, and we wrote a grant to the government of India, wherein we got the biotechnology ignition grant to digitize the entire process for facial prosthetics with the aim of remote healthcare delivery. Because what I realized during the first 10 years of my clinical practice was that even if I was willing to treat a patient absolutely free of cost, if the patient was located about 1,000 kilometers away from me, the indirect costs of boarding, lodging, travel, loss of pay were prohibitive enough for him to refuse treatment. And that set me thinking. And that's where I felt that if we are able to use digital technology effectively, we can reach the unreached. And that's what we set out to do. And but at the end of the day, you need a clinician. Technology is at the end of the day just a tool. You need clinicians on the ground to be able to treat these patients, and that gave birth to the idea of the hub and spoke model, where you can have multiple spokes at different places, train those individuals, have continuing education happening, support them with technology, and reach the unreached, as I already mentioned.
Yeah.
So the central the crux of this entire project or the idea is that the patient should not travel. It's the data that can travel through the internet.
Right.
So
Especially in these days of internet, where it is a possibility.
absolutely, absolutely. And in fact, ever since I've had this the taste of technology and what it can really do, um, I've really fallen head over heels for how technology can create such a huge impact in the lives of patients. It's unimaginable, Ruchi, actually.
Yeah, and we really need to work. I mean, we need to really work together to make that happen, because it really requires people to get together to make that happen.
Absolutely, absolutely. This is more of a mission or a movement, than just clinical, than just clinical treatment of, or rendering treatment to patients.
Yeah,
There's a
exactly.
lot that really needs to be done beyond just treating patients. There's advocacy. There is the use of digital technology effectively. Uh,
Yeah.
so many things. Business innovation.
So, as you said, advocacy, I got reminded of the other day we were talking about WHO and the know-how of, even that, that a person without an eye or a person without a partial face is, it really falls into that category of being wanting rehabilitation. Even that essence of understanding that this particular patient requires rehab, that is in itself missing there. So, I would like you to speak more about that. We did have a conversation at the back end, but I would want you to talk about that. Yes.
Sure, sure. So in somewhere in 2016, I think 2016, I was in touch with the UICC ever since I got my first fellowship, and I got the information that there was a call for rehabilitation for 2030 by the World Health Organization at Geneva. This was to be held in Feb 2017. So through the UICC, I got an opportunity to be present at one of their meetings. It was a wonderful feeling to be at the well of the house at the WHO, and these people were talking about different aspects of rehabilitation. There were different representatives from different countries. I got the opportunity to speak for about 2 minutes on the importance of head and neck cancer rehabilitation. And what appalled me really was that people were talking the connotation of rehabilitation was more in the direction of amputees, loss of vision, loss of hearing, stroke rehabilitation, cardiac rehabilitation, but there was no real mention of facial defects and the need for rehabilitation there. Now, whether I understood it wrong, or whether there was a genuine lack of awareness about head and neck cancer rehabilitation, I do not know. But not too many people that I spoke to there during that meeting, during the breaks, had an idea about head and neck cancer rehabilitation, and that was really appalling. And I'm happy to be proven wrong in this case, but I felt that there was no mention for head and neck cancer rehabilitation on the even on the WHO website, and that's where I felt that advocacy is so very important to create the much needed awareness on the ground to make maxillofacial prosthetic rehabilitation a reality in times to come.
Yeah.
So, Ruchi, even now you have many organizations that are giving startup grants for assistive technologies. All right. Now they are supporting people who are using technology to treat patients with disability. And most of them are working on either wheelchairs or bionic hands for people who have lost their limbs. People are working on different kinds of gadgets which can help people who are visually impaired. If you do not have a portion of your jaw, you cannot eat, you cannot speak properly, you cannot swallow properly. There's a problem with social interactions. If you have a missing eye, you cannot sit in, you become a social recluse. There is peer ridicule for people who are born with these kinds of defects, birth defects. But it doesn't find a mention anywhere. And unfortunately, somewhere deep down, I get the feeling that because the WHO probably hasn't addressed it yet, or there isn't sufficient awareness amongst the public, even these kinds of startup grants are not even mentioning these as part of the eligibility criteria for their grants. So I think there's a lot of work that needs to be done in this particular space, and the numbers that we are talking about are not small. If you see globally, I'm reasonably sure that these numbers are in their millions. Whereas you are a clinician yourself, so I'm sure you understand the angst there, because the kind of patient volumes that we encounter and we know for sure are very, very huge.
So as we were talking about, scaling the system, as you said. So let's talk about scaling the system and how we can do it together. One part of it was definitely having those spikes to man the main center. And then there was another one that you were talking about, which was like remote healthcare. So let's talk about that one.
Correct. So early on, as I made a mention about it as well, patients would not come to me for treatment if they were located very far off, say about 800 or 1,000 kilometers away, because the indirect costs of treatment were way more prohibitive than the direct costs of treatment. So as a result of which, what we really felt that patients should not be traveling across geographies to be able to access care. And especially in these kinds of specialized services, the doctor to patient ratio is very, very skewed. So you have very few trained professionals who can treat, who need to be available to address the needs of a very large volume of patients, which is very, very difficult for them. And that's why you need to be able to treat patients remotely so that patients don't have to travel. And the only way to do it is by harnessing digital technology. So through the support from BIRAC and Government of India and the Biotechnology Ignition Grant, we developed a digital protocol, the Pune Remote Prosthetic Technique, which was wherein no matter where the patient is located, all we need is a scan, and we can courier a digitally manufactured prosthesis to a clinician in the vicinity of the patient, and all that the clinician needs to learn is to tweak the prosthesis and to fit it onto the patient, which means that we are de-skilling the entire process. Patients don't have to travel. We are addressing the direct and indirect costs, and through this entire endeavor, we'll be ensuring, or we hope to ensure that more and more patients will have care which is accessible and affordable in times to come.
Well,
So
this would
that's
be
the
great.
crux of remote healthcare. So it's more than just telemedicine. It's not just about consulting patients and monitoring their vitals, but we are talking about actual treatment of patients. And I feel this is going to be remote healthcare in its true sense.
Yeah, it's a full treatment.
Yes. So we started with using CT scans as the digital input data, because especially in a vast country like India, the CT scans were available, are available even in the primary health centers today in a lot. So a patient who wants a prosthesis will have access to a CT scan at least in within the next 50 or 100 kilometers from where they're residing. That's why we started with CT scans. So the moment we get a CT scan in a remote hub, we are able to digitally design the prosthesis and then convert it into silicone and then ship it across. So we've had so many of these examples where a teacher has lost half of their jaw, or is unable to speak, and with prosthetic reconstruction of the upper jaw, they are able to get back to work. So in a lot of these situations, Ruchi, you end up rehabilitating not just the patient but the
Right.
entire family, because I mean, this is something that I did not realize as well, because in some instances that particular patient was the sole earning member of that family. So when you ended up rehabilitating the patient and he was able to get back to work, the impact was not necessarily restricted to just that particular individual, but the entire family.
Yeah, that's true, and it's quite satisfying. But we need to advocate more of this so that it has to catch fire and has to, and I think WHO has to look into this. This is the
Yeah,
need of
all, yeah,
the. That's true. But with this, I would say that, as you said, like, we need to have more education. We need to gather more
yeah,
people together,
absolutely.
looking forward for a common cause. And like, with having said this, I would like you to introduce the training program that you're launching. So, I mean, maybe, many people are there who would really be interested in that. And so please let us know about that one.
Yeah. So uh, all the issues that we are trying to solve today are, across different verticals. We are trying to address the entire ecosystem. So there's advocacy, there is education, there is outreach, there is research. And over the past 2 decades, we've tried to take baby steps in each of these. So one of an important part in trying to scale up is, as we already mentioned, in the hub and spoke model, you need people who are trained to man the spokes. So with that idea in mind, we decided to embark on the a training program involving the International Society for Maxillofacial Rehabilitation, a society which was initiated by Dr. John Bumer in the 90s. And I happen to be the current vice president of the ISMR. So using my good office, I had some wonderful colleagues who shared a similar vision, and they decided to support me in trying to train a few individuals in maxillofacial rehabilitation in a very structured manner. So we decided to pull in around people from almost all the continents, so that we have a different perspective on how things are being conducted in different parts of the world. And so we have faculty from different centers giving us different perspectives. And we have decided to do float a training program, which is going to be more across a combination of self-learning, assisted learning, online, on-site, essentially a hybrid model. So, and we wanted to address people at different levels of interest. So that's why we decided to keep 4 tracks, each with addressing the needs of a specific category of individuals. So we decided to have an online, all the lectures online, so that people can attend them from any part of the world. This is going to be essentially targeting students and postgraduate faculty in a lot of the dental schools across the world, because they are guiding their students, but then their maxillofacial prosthetics may not necessarily be their area of interest. But because they are guiding students which are going to be the Gen Next, they need to know at least enough so that they can guide their students sufficiently. and also the postgraduate students, so that they get a preview of maxillofacial prosthodontics and integrated treatments through an online program spread over 1 year over weekends. But for those who have a greater level of interest, we introduced a track 2, which includes the lectures, but also working on models, and then a clinical program as a track 3 program, wherein not only would they be going through the lectures online, working on the models, but also treating patients. And a track 4 for those who want to take it to take their learnings into private practice in India, where we can support them with with materials, with know-how, continuing education, so that there is an ongoing impact. So this is something. This is a part of the larger picture of the hub and spoke model that you mentioned a few minutes back,
Right.
to create people who can man these spokes and support them in every way possible.
So how long is the entire course for, if somebody was to be interested, right from the track 1 to track 4?
So all these tracks are actually happening in parallel. So because it's like a journey, you can hop out anytime. So the online lectures are the same lectures that a track 3 or a track 4 would be listening to as well. So the entire program would be running around for 1 year, with modules of 3 months each. The first month of every module would be the lectures, which everybody would attend, and those who graduate, who decide to take it further to track 3, will come down to Pune for the clinical sessions in the third month of every module.
Okay.
And there would be follow-up interactions throughout the program, and also support when all the trainees start treating patients independently.
Okay, that's
After the program as well.
right. So that's a great opportunity, definitely. And it's also a very strong unmet need. So either ways.
It is because, as I mentioned, I'm just trying to put 20 years of experience together. In the sense, it's not just about the clinical knowledge, but also its implementation in the real world. Because as a private practitioner in India, I realized that it's easier to make an obturator, but to get an opportunity to do so. So, and what I really mean by that is, you may know the skills to make an obturator prosthesis for a maxillary defect, for example, but you need to be able to reach out to the right kind of people, to be able to have all the infrastructure in place, the logistical support, to be able to get that opportunity to treat such patients. And that is what we are trying to sort of implement through this training program. It's just not an educational program, but also extends towards execution of all the knowledge that has been gained in the real world as part of your practice.
Yeah, I think it's quite interesting because you have actually sort of taken all your knowledge which you've had for the past 20 years and boiled it down to like a couple of months, actually, because it's just the weekends. So it's a great opportunity for people who would like to navigate this area of work, and it's very satisfying.
Yeah, the lectures are going to be on weekends, but when people come down for those who are interested in the clinical aspects, they would need to be coming down to Pune for about a week every quarter.
That's
for the next one.
Yeah, that's not a lot.
Yeah, that's not a lot of. It's just good enough for you to get a preview and get a solid base on the clinical protocols. The real learning happens over years. And that's what we would be, giving to all the trainees as well over time. Because what Rob and Harry really taught me is that learning is going to be continuous. And in those days when Skype and Zoom were still not the order of the day, I used to send my photographs to them very, very diligently. And they used to go out of their way to take time out and then reply to those emails on how I could have done those cases better. So this is again what I would like to translate 20 years later, that you need not necessarily be face to face every time, but you have what you mentioned now, Ruchi, is the crux of the program. It's not just about teaching people maxillofacial prosthetics. It's about maxillofacial prosthetics integrated with plastic reconstructive surgery integrated with oncologic principles, radiation oncology, using digital technology.
At the end of the day, the primary complaint of the patient is that we have to be able to give him the ability to eat.
Absolutely. And 10
Yeah.
years back, Ruchi, when I would have never imagined that I would be so much involved in technology. As a clinician, 10 or 15 years back, I was probably doing a lot of stuff manually. And I would have never imagined that I would be sitting face to face with an engineer and trying to solve these very, very complex problems. And engineers today as well are excited. They feel that they can create a lot of impact in society and put their skills to use in a completely different domain and impact people that even they had not thought about.
Exactly.
So it's very, very exciting to work with people coming from domains which are not yours. So you have to be a patient listener and try to imbibe. It's not just multidisciplinary but interdisciplinary approach, which is going to be the order of the day.
Yeah, and I think that's why collaboration is the key.
Yes, collab. I think like someone said, alone you can walk fast, but together you can walk far.
Yeah, that's the one. Yeah.
I would say that's the crux.
Yeah. So yeah, we need to work more and more together and with more people and bring this. This should be the reality of tomorrow.
Absolutely. I think there should be no one anywhere in any part of the world who should be walking around with a defect on the face and in search of a professional and thinking to himself that there is no light at the end of the at the end of the tunnel. There definitely is, and using technology today, you can treat any patient in any corner of the world. And I think in India, we have been able to do it frugally.
Yes.
I think I would say the Make in India program that the government has really introduced about 10 years back today has caught the imagination of a lot of professionals today in India and has given us the belief that we can do things that the West is doing, and not just that, as good as probably they can do, and most importantly at a fraction of the cost at which they can do.
Yeah, and the more we do it locally, the problems that are there locally are also very different from what it is in the other country. So
Yes.
we can solve those problems as well.
Absolutely, and especially for a country like India, where 85% of the healthcare is in the private sector, and where patients are required to pay out of their pocket for these kinds of services, you have to keep it frugal in order to create the much needed impact.
So I would say that, as you said, we need to have more education. We need to gather more people together, looking forward for a common cause. All the people listening who would be interested in this kind of a program, please, you would contact Dr. Srinivasan, and I will be dropping down the details here. And thank you for being there today. It was a pleasure listening to you. And your journey has been amazing, and it's a lot to share so much in a short span of 1 year. So thank you for being here today. Thanks.
Thank you so much, Ruchi, for this opportunity.